Hello, I'm Chris Salisbury, and today I'm talking to Martin Roland, who's the Emeritus Professor of Health Services Research at the University of Cambridge. And Martin's been one of the most influential academic GPs in the UK over the last 20 or 30 years, particularly in terms of the impact of his research on policy. So, Martin, thanks very much for joining us.
Thank you for asking.
Let's go back to the beginning. Have you always wanted to be a doctor?
Yes, I wanted to be a train driver up till I was about 7, but after that I wanted to be a doctor. And it was I'm afraid largely because my father was a doctor, and actually my
Right.
grandfather was a doctor as well. So without too much thinking, I never really deviated from that throughout school. I was very happy and I've always been comfortable with the idea of being a doctor.
And did you think you'd become a GP?
So I trained in Oxford. I went to Oxford, and one of my consultants was director of clinical studies. So he was kind of in overall charge of the clinical school. So I had an interview with him at the end as I left, having been his houseman for 6 months, and said at that point I hadn't decided whether to do pediatrics or general practice. And he strongly urged me not to do general practice because he said, in his words, he thought that would be a waste. I've actually very recently had cause to chat to him about that again, and he remembers saying that. He's now well into his 90s. And he said, well, I suppose you made a decent shot of it.
So what led you to start doing academia?
That was kind of accidental. So so towards the end of my vocational training, I got engaged to my then wife, who was a pediatrician. So it's probably just as well I didn't do pediatrics. And she was moving to a lecturer's job in London. And so we're pretty sure we didn't want to live in London long term. And in those days, if you joined a practice, you really joined for good. So I was looking for some sort of job in London in general practice for a few years. And I thought, having done the odd bit of sort of minimal trainee research, that maybe working in an academic department would fit that bill. So I actually looked around, and I found a couple of people who I thought would be interesting to work for. And one of them was David Morrell. And I wrote to him and said, any chance you've got a job? And he was about to advertise a lectureship in general practice, which I applied for and got. So I then spent that 4 years in a really good research training environment at St Thomas's.
And is that when you did your PhD?
Oh, do you want to know the story of my doctorate?
Well, I was going to ask you about that because you did this on back pain, which isn't the most obvious topic for the rest of considering the rest of your career.
So I had a number of false starts as to what to do for a doctorate, and doctors mostly did MDs in those days, and hit on this subject of looking at the natural history of back pain presenting in general practice. And it was supervised by David Morrell and also Walter Holland, who was professor of epidemiology at St Thomas's at the time. And I had a choice of submitting to London, where I was a lecturer, or Oxford, which was my alma mater. And I decided to go for Oxford because they had really, really smart DM gowns, which I'd seen before. So I submitted to Oxford, which in those days was an unsupervised degree. You just simply did your thesis and you submitted it. And they didn't viva either unless you were borderline. And after a few months, the result came back saying it was a straight fail, which was, I have to say, a bit of a bummer at the time. Slightly ironically, the papers that came out of that study are by far my most highly cited papers and still being cited quite regularly. But there was no appeal at Cambridge. So what I did then was to do another study related to back pain, cut the other one down by half, tagged this on as an extra study, so there were 2 studies in the thesis, talked to the Oxford head of department and tried to ensure that I didn't get 2 orthopedic surgeons examining me this time, which is what had happened last time, and finally got my doctorate. But it did take 9 years in the end, so it was a little bit of a struggle.
And I guess
and did I go and get it in person? I certainly did.
And You're the third person I've interviewed, and one theme that comes out of all interviews is that things that seem a disaster at the time, we very few of us have a straight line to success. Things happen along the way.
Exactly, and things that think bad things happen, and they aren't always terminal.
So I first met you were in Cambridge, and you must have moved to Cambridge, but then you went to be professor in Manchester and established the National Primary Care Research and Development Centre, which was very influential, I think. Tell us about that. What was that about?
I mean, it was a very fortunate time to move because very shortly afterwards, the government advertised a contract for the National Primary Care Research and Development Centre with £15 million, which was a huge amount of money at the time in the early 90s, on a 10-year contract, both of which really were unheard of before. And we applied from Manchester jointly with York and Salford, and were just exceptionally fortunate to have got that. And that ability to have long-term funding, to be able to think long-term about the sorts of projects that you could do, to be able to give staff reasonable security of tenure, made a huge difference to what one could achieve. We had a steering committee from the Department of Health who came and reviewed us after 1 year. And some of the civil servants were minded to close us down in that we hadn't really made a difference to anything within a year. But fortunately, there were other guys on the committee who said, actually, things take a little bit longer than a year. So it was successful in a number of ways. It was successful in providing career development for, I haven't counted, but really a substantial number of people who went on to chairs elsewhere. I think between 12 and 15 probably. So it proved to be a really good training ground for academic staff from a range of disciplines. And it was essentially, and my work has always been very multidisciplinary. So yes, clinical doctors were often at the heart of things, but we had economists, we had sociologists, we had statisticians, psychologists, and my ethos has always been that you need, if you want to do a particular piece of work, first think about the expertise that you need to do that, and then make sure you've got really good experts in those areas.
And then, not that long after that, there was the introduction of the NIHR School of Primary Care Research, and you became the first director. Do you think that's been a success?
Well, it's obviously a very different model because it's funding spread between a number of different schools, and it has certainly enabled a number of things to happen, including really important things in terms of career training and development, because there's some really, really tricky gaps in people's careers when they want to become academics. For doctors, especially if they're specialists, they're going to face a big reduction in income if they don't become NHS consultants with a private practice. There's a big gap time between finishing your PhD and being able to get some sort of tenured or semi-tenured post. And one of the things that I was pleased to be able to do was to sit on the Walport Committee, which was in the mid-2000s, at a time when academic medicine generally seemed to be under real threat, partly because of the RE rules, and establishing some sort of career pathway and academic clinical fellowships that general practice has benefited from significantly. And I think the school's been able to do that. I think I don't know. There's no doubt that it's provided very good funding for some excellent work to happen. To what extent those have been collaborations between the universities, or it's just strengthened the individual members, I'm not sure, which doesn't mean it hasn't happened. It just means I don't know, I think.
Sure. And then in 2009, you moved back to Cambridge as Roland Chair in Health Services Research.
Correct.
I mentioned your research has had a huge impact on policy, and I've got three things in mind, and you might think of others that you think you've had more impact on. But the first I want to ask you about is your research on patient experience, because I remember you developing the general practice assessment survey and there was the incentive for practices to do financial incentives to do surveys. And then I think you were very instrumental in developing the National GP Patient Survey. How much do you think they've really fulfilled the aim of improving quality? Or what have they achieved?
Both of the things, all those things you said are correct. I've been very influential and very involved in all of those things, and I think they've made hardly any difference to policy.
Why do you feel that?
If I give you an example, so governments for years have been obsessed with access to general practice, and they have consistently failed to understand the importance of continuity of care, and that there's a trade-off between those two things. So in the very first iteration of the National GP Patient Survey, I and one or two others fought pretty hard to try and get something in continuity of care, and we weren't going to get much. And in the end, we were only allowed two questions which relate to continuity, which were, is there a particular GP that you prefer to see? And if there is, how often do you get to see that doctor? Probably partly because politicians aren't very interested in it. That question has survived over 15 years, and therefore we've been able to track longitudinal continuity over that whole period of time and watch it decline and decline and decline. And governments have occasionally said that they might try and do something about it, and this government, in their manifesto, has said they'll do something about it. Whether they actually will, we shall wait and see. But I mean, that is an aspect of performance that has been demonstrably declining very substantially in the last 10 or 15 years, but has been ignored by policymakers. So no, I don't think patient surveys have done very much for what policymakers do. And frankly, I doubt very much that they've made an awful lot of difference to what practices do. They've been tremendously useful for research, though.
Absolutely. There's been a whole minefield of papers coming out of that. I mean, not only for you, but for lots of other people. What's one of the great things about it is that so many people have done studies based on the data from that. So your interest in surveys, I see, is linked to your kind of overarching interest in how we measure and improve quality. And again, I think of you as one of the main architects of the quality and outcomes framework in England, introduced in 2004, which has, again, generated lots of papers, but has definitely had a big impact. What do you think about its pros and cons looking back? Well, not looking back because it still exists.
Yeah. Well, one of the things that people don't always realize is why QOF was brought in the first place. And it came at the time when the Blair government decided to put a major boost of NHS funding and commit to increasing to mid-European levels in terms of percent of GDP. And as soon as that happened, the hospital doctors, of course, thought of all sorts of ways of spending the money because they're really, really, really good at that. And the GPs were a bit stuck for what they were going to do. And there was at that time, which was right at the end of the 1990s, there was a real recruitment crisis in general practice, and general practice pay had fallen substantially behind that of hospital doctors. And there was a tacit agreement between the Department of Health and the BMA that GPs needed a big pay rise. But the problem was that Treasury were not going to give them money for nothing. And so the kind of deal was that what the GPs would offer was quality, and in return, they would get a decent pay rise, which happened. GPs got something like a 25% increase in income over that first year or two, and there was a big improvement in GP recruitment. So for that unstated aim, it was entirely successful. If you look at financial incentives to improve quality of care in the UK through QOF, or frankly anywhere else in the world where they've been evaluated, and we were probably ahead of most countries, and many countries have followed in one form or another and continue to do so. I think that there's a number of universal truths. The first is that financial incentives improve quality, but not very much, and usually nothing like as much as the payers think they're going to. And secondly, that for quality improvement generally, there's no magic bullet. There's no single thing that improves quality of care. And what QOF came on the back of was a whole raft of things that were going on in the late 90s and early 2000s under Liam Donaldson's general umbrella of clinical governance. So the development of national clinical guidelines, development of compulsory audit in general practice, initially private release of information on quality of care, and then public release of information on quality of care. So a whole raft of things, compulsory audits that trainees had to do, which was a new thing to quite a lot of trainers. So there were a whole raft of things that QOF came on the back of. And so what there was clear and documented improvement in quality of care in a number of areas before QOF came in, and QOF made a little bit of difference, improved things a bit more. Of course, since then, we've had another natural experiment of Scotland removing QOF, or removing the financial incentives for quality, but being able to continue to track quality of care. And that's been quite interesting, because what's happened is that the things that are simply tick boxes drop like a stone as soon as you take the incentive away, because people don't have an incentive to tick the box. But other things that are more objective measures of quality, such as actual measurements of cholesterol in people with heart disease, they've actually shown that quality appears to have got less good when the incentives were removed. So we've got evidence of some improvement, but not as much as a lot of people would like, and some reduction in quality if you take the incentives away. But they're not the big either stick or carrot that people imagine they might be.
But some people feel, I feel, let's be clear, that it definitely has some advantages, but at the cost of a loss of professionalism. And you said in an editorial once that quality initiatives need to win hearts and minds. And I wonder whether QOF does win hearts and minds, or just leads to a kind of tick box ticking attitude that undermines professionalism and paying lip service rather than actually believing in what you're trying to do.
Well, there's no question that however you pay doctors, so there are risks and benefits to all the methods of paying doctors. So if you just pay them with a salary, there's a risk that they'll take the money and not do anything. If you pay them fee for service, they'll do loads of things, whether or not it helps the patients, and there's plenty of countries that do that. If you pay them on quality, then they might do just those things and nothing else, and might come on to some of the things they don't do through QOF. If you pay them on capitation, then the incentive is to have as many people as possible, but not necessarily provide care that's any good. And that's the reason. There's two things that are consequences of that. One is that probably, and most countries aim for some sort of balanced payment system that includes both the benefits and tries to minimize the disbenefits of each of those payment systems, because they all have disbenefits. But the other thing is that whatever you do, you rely hugely on the professionalism of doctors. And if you lose that, then you're in serious trouble. So one of the things that's terribly obvious from things like QOF is that some things are much easier to measure than others. So I don't know how many indicators there were on diabetes in the first iteration of QOF, maybe 15 or something. I mean, a lot. And how many on mental health care? Hardly any. Simply because mental health care is difficult to measure. So you prioritize in people's minds things that are easy to measure, potentially at the expense of things that aren't. And that's it's very hard to know how much of a problem that is. I think there is possibly a difference between QOF in its very early days and as it's subsequently iterated. So in the early days, the government thought that they wouldn't have to spend too much on QOF in the first year or two. BMA were pretty sure the GPs would get all their money more or less straight away, because they were pretty sure that quality was pretty good. And they were right, and it was, and GPs got almost all their money almost straight away. And those early indicators were pretty much low-hanging fruit. They were mostly things that people thought they should be doing anyway, and were quite pleased to be paid for doing, and they mostly were doing them. I think that since then, QOF has become more of a burden as people's lives have become generally much more pressed, and demand has increased. There have been some really, really bad ideas of introducing into QOF things that basically had a managerial focus. And so there you've got the if you've got financial incentives that cut against professional values, then you're in serious trouble. Ideally, if you're going to have financial incentives at all, they are fully in line with professional values.
I would happily talk about QOF for ages, but I want to allow time to talk about one more thing, and that's your changes in the primary care workforce, because in 2015 you chaired the Commission on the Future of the Primary Care Workforce and recommended expansion of lots of roles like physicians associates and pharmacists and physiotherapists in primary care, and that's now happened but proved to be very controversial with the R's scheme. Have you got any reflections on that? Has it turned out as you planned?
In parts, yes. So our first recommendation was that we needed 5,000 more GPs, and the government committed to producing 5,000 more GPs by 2021. And at that stage and now, we still have less full-time GPs than we had then. And the reason for that is not that they're not training more. They're training more than they've ever trained before, but they can't stop people leaving. We were spot on in saying more GPs were needed, and government need to provide them. I think that some roles in general practice have been really useful. I think direct access to physio is useful, but I want to say a little bit more about that. I think pharmacists in practices have been really useful. And we used pharmacists, employed pharmacists in our practice in Manchester going well back into the 1990s, and it made things like repeat prescriptions miles easier. Physician associates are a huge problem, as you know, because what we've ended up doing is giving them a task which actually needs some of the highest levels of skills to the GP, i.e. dealing with undifferentiated illness, to people who have among some of the lowest levels of skills. What I think that has been a misapprehension by government, and probably completely predictable, is that these things would reduce GP workload. So, for example, we've evaluated the impact of direct access to physiotherapists in general practice. And the bottom line is that in sort of nice terms, cost per quality, physiotherapists are fantastically cost effective. They come out really good in terms of cost per quality, and make not a jot of difference to GP workload, and are very popular with patients. So, a good extra resource, but is it the answer to GP workload? No, it doesn't seem to be. Now, of course, if you gave them prescribing and sickness benefit writing rights, you might change that a bit, but that's been the situation. That's an example of, I don't know about an unintended consequence, but a consequence not realized. And there have been quite a few NHS developments which have been really popular with patients, but have not had the effect of dramatically reducing GP workload or A&E attendance or what they were intended to do.
Now you've retired, and I remember you telling me one of the great things about being retired is that you can still work, but just do the things you feel like doing. And you've become ambassador for the Women's Art Collection at your college in Cambridge. I hope you won't mind me saying you don't seem the most obvious person to be the ambassador for a women's art collection. What's the,
Well, okay. So Mary Edwards College is one of two Cambridge colleges that admits just women students. All the others admit both men and women. We, as well as educating smart young women, we think we have a role in society in promoting the place of women more generally, and do various things, including collecting art by contemporary women artists. And we've got, apart from one museum in the States, we've got the world's largest collection of contemporary art by women artists. And fellows of Cambridge colleges, there are all sorts of committees that have to be done. There's gardens committees, admissions committees, and an art committee. And I ended up chairing the art committee for quite a number of years personal interest in art that goes back to some of my family background. And so that's been a great bit of retirement, as well as some of the academic bits that people still ask me to do. And I enjoy both. Before I retired, somebody asked me what I wanted my legacy to be. I thought about that a little bit. And then one of the things I think your legacy is unquestionably not is the many papers people like you and I have published over the years, because in a few years' time, there are very few of them will still be being quoted. And I think our only real legacy is the people we train and the people we influence, because they're the people who carry on the values and as well as the skills that we've given them. So I think, to see quite a few people who've worked with me going on to do other good things have been also very rewarding indeed.
Great way to end. Thank you. So you've had an incredible career and you've managed to do research that's really relevant to issues of the day. And in fact, you've quite often set the agenda on some of the issues of the day. We've talked about your influence on policy, but I know that you've had an influence on lots of people's careers as well. And a lot of people have learned from you. So thank you so much for talking to us today.